Hello and welcome to another episode of Intellectual Calisthenics. I am indeed honored and privileged to have as my guest Dr. Uday Ghoshal. Professor Ghoshal is a professor at the Sanjay Gandhi Postgraduate Institute at Lucknow. For those of you who don't know, that's a very prestigious institute in India. And Dr. Ghoshal's CV actually reads much longer than that, and I'll post the details on the video text. But one of the unusual things about Dr. Ghoshal is he is a clinician researcher. So, what does that mean for most people? He is a clinician, which means he actually sees patients in the hospital, and he's also a researcher. So he actually does research. So things like which is the medication which is going to work in this group of people in this kind of a gastroenterological problem. So he is someone who has published many papers in very prestigious journals. And Dr. Ghoshal is a fellow of the Rome Foundation. And very soon, Dr. Ghoshal, you'll tell us what the Rome Foundation is. And he's also a reviewer with the very prestigious Nature journal called Nature Reviews Gastroenterology and Hepatology. And Dr. Ghoshal has written a lot of textbooks actually for specialist gastroenterologists. He has many areas of expertise. One of them is motility disorder, so it's how your bowel moves. Very interesting areas of research, and very really thank you so much, Dr. Ghoshal, for being here. And before I start sharing our PowerPoint, Dr. Ghoshal, will you tell us what the Rome Foundation does and what is it? Why is it so important for gastroenterologists?
Yeah, Rome Foundation is an academic body. Now, this Rome Foundation is particularly interested in a group of disorder called functional gastrointestinal disorder. The aim of the Rome Foundation is to make the life of patients with functional gastrointestinal disorder better. In fact, Rome Foundation has been actively involved in making this disorder legitimate. Earlier, many of these patients were ignored by physicians and gastroenterologists, but because of the work of Rome Foundation, these disorders are very well recognized. Rome Foundation makes the criteria for diagnosis of functional gastrointestinal disorder. In fact, in 2016, we released Rome 4 criteria. Not only the criteria, but it makes algorithm how to diagnose these disorders, how to treat these disorders. And also Rome Foundation is involved in many high quality studies, multicentric studies on functional gastrointestinal disorder, some of which I'll share during my presentation today.
Thank you, Dr. Ghoshal. So when you say functional GI disorders, what does it actually mean for someone who doesn't know what it is?
Functional gastrointestinal disorders are a group of disorders in which patients suffer from symptoms, chronic symptoms, that mean long-term symptoms, but there is no anatomical basis for these symptoms. Earlier, it was thought that there is no organic basis, but we are gradually realizing that some of these disorders actually has organic basis at a microscopic level. That's why we call these are truly microorganic disorders. So these are chronic disorders which lead to a lot of suffering of the patient. But when you do diagnostic tests, many a time you will not get a real abnormality on the different diagnostic test. But what will happen is that these disorders are diagnosed by symptom-based criteria as of today.
Thank you. So, Dr. Ghoshal, that was very interesting. And actually, before I started recording, I didn't talk about our topic today. So, our topic today is small intestinal bacterial overgrowth in irritable bowel syndrome. Is it a real association or is it unnecessary hype? Now, irritable bowel syndrome, Dr. Ghoshal will talk about what it is, what are the symptoms, and what is SIBO, where does SIBO come into this whole picture? So, Dr. Kushal, when you say that there is no structural abnormality, so for a layperson, it would mean, as you said, the gastroenterologist does an endoscopy, patient goes to the gastroenterologist with certain symptoms, and we'll come to the symptoms also. So most commonly it is pain accompanied by a change in the bowel movement, sometimes constipation, sometimes diarrhea. There can be bloating and, early fullness after food, a lot of different symptoms. But when the gastroenterologist puts in a scope, they don't see any abnormality in the endoscopy. But in terms of function, obviously the gut is not functioning the way it should. So is that a simplified version? Now,
Yeah, that's right.
when you say that, the different Rome criteria, Rome 4, Rome 2, Rome 3, all these other things, for those who are not specialists in this field, it's actually, many of them don't even know that. So Dr. Ghoshal, I know in one of your other videos you said that someone had done a study to check whether uh, doctors are actually following the criteria or not. So I'm not talking about gastroenterology specialists, so let us say a primary care physician. How much do you think are they aware of what the Rome criteria is? How should they make a diagnosis of IBS, and what has changed, which is so very interesting?
Yeah, see, what happens is that I know many of the physicians are not aware about Rome 4 criteria. In fact, there have been studies on this issue showing that gastroenterologists are more aware of Rome criteria than the physician. Even among the gastroenterologists, let me tell you, every gastroenterologist may not be familiar. But you need to diagnose this patient. So when you need to diagnose this patient, even if you are not very familiar with the criteria particularly, but still you need to know that these patients are chronic, are having chronic disease. What does chronic disease means? They should be having symptoms which started 6 months ago. So by this arbitrary 6 months, we are trying to say the disease is chronic. Second is they must be having the disease at the time when they came to your clinic. Because if somebody started having symptoms 6 months ago, but when they came to your clinic, they don't have the symptom, obviously you are not going to diagnose IBS. That's why we are saying they should be symptomatic currently during last 3 months. So by 3 months, we are meaning that the patient is currently symptomatic. Onset 6 months ago, we are meaning that the disease is of long duration. And what is the primary symptom? Primary symptom is abdominal pain. But I tell you, if you ask people, you will find a lot of the people who are otherwise don't suffer from this disorder. They will say, sometime I did have some abdominal pain. That's why we put down a frequency. The frequency must be at least 1 day per week. So abdominal pain frequency must be 1 day per week. But only pain does not mean IBS, because IBS is a syndrome. IBS is not a disease. So therefore, there should be a combination of other symptoms. What are the other symptoms? The pain should be related to defecation. That means when somebody passes stool, pain may be increased or pain may be decreased. It should be associated with change with the frequency of the stools. For example, somebody says, whenever I have pain, I ideally go to the toilet very often, 4 to 5 times a day. So this is pain is associated with change in the frequency of the stool. And it should be associated with change in the form of stool. What is form of stool? It should be either loose or should be hard. And of these three criteria that I have listed below, at least two of these must be present to diagnose somebody having IBS. But let me tell you a point here that we have found in many countries, including India, particularly India, pain is not the major symptom. And this resulted into a situation that by Rome 3, in which discomfort was one of the essential symptoms, now when you apply Rome 4 to them, because we have removed discomfort, actually a lot of patients are not diagnosed as IBS by Rome 4, though they are diagnosed as IBS by Rome 3. So therefore, I will advise the physician that you may not go line by Rome 4 to diagnose IBS patient. Actually, sometimes even the Rome 3 is good enough to make the diagnosis.
Dr. Kushal, this is very interesting because you bring the Asian perspective. So, in the Western world, IBS is supposed to be more common in women. But I think in your studies and in just general practice as well, we know that in India, a lot of men have IBS. So, that was an interesting finding, I think, that you contributed to. Am I right?
Yeah, that's right. So we found that man and female or male frequency of IBS is somewhat similar
Similar.
in Indian patients.
So this is again the very interesting study. So, Dr. Kushal, will you tell us what does this mean?
Yeah, you see, everybody will like to know how frequent are these disorders in the world. Now, because you need to know the burden of this disorder or frequency of these disorders. So for this, under Rome Foundation, we did a study, and this is one of the biggest epidemiological study in GI in the world. It included 33 countries in 6 continents, more than 73,000 people. They are from community. In some countries, we did internet survey. For example, 23 countries, particularly in Europe and America, we did internet survey. In 10 Asian countries, particularly, we did household survey. And in 2 countries like China and Iran, we did both household and internet survey. And what we found is that functional gastrointestinal disorders are quite common. In some countries, the frequency was as high as 40%. But
Hmm.
fortunately, in India, the disorders was less common. One interesting finding that we had in this study is when you do an internet survey, the frequency is higher
Yes.
than when you do a household survey.
That is very interesting. So, Dr. Kushal, would you say that in countries like India, it is somewhat underdiagnosed if you just go by, I mean, your friends and relatives? How many friends and relatives do you have who don't have some GI issue? And I'm sure they catch hold of you at weddings and parties like that to ask you as well. My suspicion is it is underdiagnosed. Am I right?
Yeah, you see that when you try to diagnose a disorder uh, in using a criteria that is developed in the West, the problem is maybe there are issues in the language, there are maybe issues in the threshold. For example, you see, I would say you know better than me that in developed countries, maybe you will say no pain, no pain. You will say nobody should have pain. We teach our children from the childhood no pain, no gain. So you must have enough pain to gain something in life. So therefore, our threshold to tolerate pain is much higher than the threshold in the West. Now we made Rome 4 criteria where pain became essential and the threshold also was increased. The moment you do that, the people who had IBS, they lost their IBS diagnosis, and there are data to show that when somebody applied this Rome criteria 3 and 4 in China, they found a lot of patients of IBS by Rome 3 lost their IBS diagnosis. There is an Indian study from northern part of India
Mhm.
recently published showed the same. And in fact, our global epidemiology study showed it may not be true only in India or maybe in Asia. It is true everywhere in the world. Rome 3 is more sensitive to diagnose IBS than Rome 4. So therefore, I would say it is not really, it is not really that you don't have this disorder. This disorder must be common, but maybe you are not diagnosing them because of the criteria.
Mhm.
Second thing, this interesting finding that internet survey gave higher frequency. I always had something in mind that if you do an internet survey, there is a possibility of recruitment bias.
Yes,
Maybe those
absolutely.
who have the
Yes.
disorder will tend to actually report to you or fill up the survey questionnaire, and therefore you may overdiagnose.
That is true. And also, it is possible that this group of people are the ones who are continuously symptomatic. They have not got the relief. And this is not just from IBS, even in hypothyroidism, PCOS, in other internet surveys as well. So, yes, there is definitely a bias. And so the interesting thing is, number one, what is the connection between small intestinal bacterial overgrowth and IBS? And Dr. Kushal, will you just tell people what is SIBO actually? So before I move on to the next slide.
Yeah, you see that normally the upper gut is supposed to be sterile. That means jejunum,
Mhm.
duodenum is supposed to be sterile. If at all it has bacteria, the number of bacteria is typically less than 10 to the power 3 colony forming unit per milliliter of the gut aspirate. Now, when somebody has overgrowth of bacteria in the upper gut, for example, duodenum and jejunum, to the tune of 10 to the power 5 or more colony forming unit per milliliter of aspirate, we consider this as diagnosis of small intestinal bacterial overgrowth. However, recently we saw that actually 10 to the power 5 is rather a high cutoff, high threshold.
Mhm.
Patients who have between 10 to the power 3 to 10 to the power 5, they have also a lot of clinical meaning of this type of overgrowth of bacteria, and we named it as low-grade small intestinal bacterial overgrowth. And I can share with you the data that these patients who have 10 to the power 3 to 10 to the power 5, if you treat them with antibiotic, they respond better than those who have below 10 to the power 3. So therefore, we say SIBO conventionally is diagnosed when you have bacterial overgrowth more than 10 to the power 5 colony forming unit per ml or equal to 10 to the power 5 colony forming unit per ml. But between 10 to the power 3 to 10 to the power 5 is also clinically important. And this would be called as low grade small intestinal bacterial overgrowth as we proposed.
Thank you. Dr. Kushal, when you say that this is a colony, a certain specific colony number in the small intestine, so which would imply that diagnosis has to be through an invasive test, or does it have to be through a breath test? So how would someone diagnose SIBO other than going by symptoms? Because symptoms are fairly non-specific, like bloating, and some of them may have pain and things like that. So diagnosis is always by an invasive test or by a breath test. Am I right?
I tell you that small intestinal bacterial overgrowth, the diagnostic gold standard is aspirate.
Hmm.
But as you said rightly, it is invasive. It really requires a good microbiology lab, and I'm lucky because my wife is a microbiologist.
Oh, wow.
So a lot of work that I do, I owe to her. I owe to her. It is all that she does, and I actually tell the world this is what it is. So
Thank
credit largely goes to her. And I tell you that, but invasive test is not easy to do. It
no.
requires microbiology lab. It requires sort of invasive techniques. So therefore, breath tests are reasonable alternative. But unfortunately, the breath tests are neither very sensitive nor very specific. We typically use in our setup for clinical purpose glucose hydrogen breath test. And let me tell you, sensitivity of glucose hydrogen breath test is quite low, 30 to 40%, but specificity is very high, 80 to 100%. That means if somebody is glucose hydrogen breath test positive, I'm quite sure that that fellow has bacterial overgrowth, but he is negative. I know still he could be having bacterial overgrowth. We need a better diagnostic test, and there are a lot of things which are evolving, but because these are very technical, I don't want to actually elaborate on this.
Yes, and most of those are not available to just any person. Like how in India people can just go to a lab and
Yeah.
get a test done. It's not available like that. And later on, at the end of your presentation, Dr. Kushal, I will come to this question on whether you think it is worthwhile to treat SIBO without doing all the tests. That is for later. And I know someone who's a researcher like you. Ideal circumstances, we'd like to test and we like to know for sure whether the person has it, but maybe we'll go to that discussion later on. So this is one thing. And This is a very, very interesting slide. And this is how in my world of functional medicine, we look at any problem as a multi-pronged, network of network problems. So Dr. Koshal, over to you to explain this slide.
You see that is a very important slide to tell you IBS has multiple pathophysiological mechanisms. Like earlier, we thought it is a psychosomatic disease. It is largely because of psychological factor and stress. But as time is passing, we are realized there are multiple peripheral mechanisms in the gut itself. And some of these peripheral mechanisms include visceral hypersensitivity, altered motility, inflammation and abnormal intestinal permeability, dietary issues, pathogenic infection, altered gut microbiota, local neurohormonal dysregulation, and genetic factor. In fact, I will elaborate on these during my presentation, at least some aspect of it, but we'll primarily focus on altered gut microbiota today. Gut microbiota alteration can be of two types. One is there is a qualitative change in the microbiota, which we call as one form of dysbiosis, which you use next generation sequencing to know the change in the quality of microbiota, but that is not what we are going to focus on today. What we are going to focus on is a quantitative change in the microbiota, which is called small intestinal bacterial overgrowth, which I already defined for you.
Thank you. So Dr. Kushal, just stepping back a
Yeah,
little
next.
bit, before I go to the next slide. Now, one of the major differences in the new Rome criteria is describing IBS as a problem of the gut-brain axis instead of calling it a functional GI disorder. So will you explain what has changed and why is that definition so important? Why calling it a gut-brain axis problem and not even a brain-gut axis problem? So will you elaborate a little bit on that? I know we are going away from SIBO, but this is information that a lot of people don't have.
But actually, you, yeah, you can go to the next slide. I think there is a slide for
Okay.
this. You can go to the next slide. Maybe I
Yes,
just
yes,
see. Yeah.
you're right.
Next, next. Go next,
Next
next.
one.
One
Okay.
more.
Yes.
Yeah, yeah, go. Yeah. Look. Previously, we said that IBS is a brain gut disorder. But we realize over the time that there are too many pathophysiological mechanisms in the gut itself rather than in the brain. So that's why we change the terminology that it is not the brain gut disorder. Putting brain over the gut may not be really right, but gut is the primary because I told you in my previous slide how many peripheral mechanisms were there in the pathophysiology of IBS, and therefore we change brain gut disorder to gut brain disorder. Second is that they go back to the previous slide. Yes, previous. Yes,
One more.
we thought the word functional. No, this is fine. We thought the word functional actually was leading to disservice to this patient because we thought functional means it is a disorder of function. But physicians and many others actually means idiopathic or cryptogenic. They thought that patients are neurotic, they're only apprehensive, but otherwise healthy individual with an imaginary illness. So what was happening is the patients were not getting the due attention from the physician, from the gastroenterologist. They were thought neurotic, apprehensive, otherwise healthy people. That's why I made the picture on the right side, which I like. I say IBS is related to the fact that what is happening inside the gut, what is happening inside the gut, how the gut immune system is responding to the luminal phenomena, and then how GI events are sensed by the nervous system. What are the food that the patient is taking, and how these foods are handled by the microbiota that the patient has. So it is a complex disorder where a lot of event happening in the gut from the food by the microbiota. The immune response may be exaggerated, and the visceral hypersensitivity may be there, which is leading to inappropriately exaggerated sensation from the from the gut. Also in the brain, the sensitivity may be abnormal. For example, whatever events happen in the gut, people are supposed to sense it by their primary sensory areas of the brain. But what happens in IBS patient, there is an exaggerated sensation in the primary sensory area, but also there is an inappropriate activation of the emotional arousal area, which lead to panic, and therefore there is an exaggerated symptom reporting. So all this together makes IBS. So that's why we remove the term functional and we put the brain below the gut.
Thank you. So the brain and as the gut is sometimes described as the second brain. So the important distinction between the two is this is not the brain which is involved with all the executive functions like, goal setting, goal achieving, doing the harder, difficult things. Those are the big brain's functions. But the second brain in the gut, which actually directs the brain up in the head as well, it's more involved with these kind of conditions, as Dr. Ghoshal has described, things like mood, things like, as we say, that gut feeling. So these were actually terms which have been in use for a long time. Now we are finally understanding what is happening. So there is a nervous system in the gut, and today, in the interest of time, we are not going into the enteric nervous system and the other big nervous system in the brain. And the vagus nerve is one of the main areas of interaction between the two. So that will be for another, I think, another video, Dr. Koshal, we will need. So this is the bidirectional relationship that you were talking about. So will you explain a little bit?
Yeah, this is a very good study. Let me tell you what these authors did is, I think it is from Nick Talley's group. So what
Mhm.
these authors did is they took patients who are anxious but don't have functional gastrointestinal disorder, and they followed them over 12 years. And they found anxious people tended to develop functional gastrointestinal disorder more often. But more important than that is look at the part below. People who have
Mhm.
functional gastrointestinal disorder, when they are followed up for 12 years, they develop anxiety more often than those who do not have functional gastrointestinal disorder. That further proves that in a large group of patients, it is the FGID which drives their psychological issues rather than psychological issues leading to FGID. This is another evidence to suggest that gut should be put over the brain rather than brain being above the gut.
Thank you. So, Dr. Ghoshal, this is very interesting because you talked about the immune system in the last slide, how there is an immune disbalance because of which IBS is one of the syndromes that shows up. Now, in the last few years, as you know, there have been a lot of research on, GWAS studies on mental health and all these. And interestingly, anxiety, depression, a lot of the psychiatric problems have also been found to be intimately associated with inflammation and the inflammation genes. So probably could this be one of the interrelationships? Maybe those genes which lead to anxiety in some people also have some commonality with functional GI disorders. I'm not sure any studies have come out with the genetic aspect, but would that be one of the interrelationships?
Possible, because you see there is a clustering of the functional gastrointestinal disorder in the families. So like
Hmm.
even twins and all those studies, and also we know functional gastrointestinal disorder tend to have all these psychological issues more often. It means there should be a common basis not only on the environmental factor and the gut microbiota related factor, but also the genetic factor of the host.
Okay, so what are the biological factors for IBS?
Because I want to tell it, you know why. The reason is we are talking about SIBO.
Hmm.
So when we are talking about SIBO, we are further trying to reiterate that don't consider that every patient with functional gastrointestinal disorders have a lot of psychological issues.
Yes, you're right.
Also try to understand if you are seeing patient in primary care or secondary care setting, you will see a lot of patients who have actually hardly any psychological issue. They have functional gastrointestinal disorder. When you move to tertiary care practice, then what happens is you will tend to have referral of those patients who have severe disorder, who have overlap disorder, who have more psychological issues. And also we have to actually accept that most of the studies that actually came to the literature came from those kind of tertiary practice. So therefore, these have been highlighted too much. In fact, in India, we have a different kind of healthcare system. Though we are in the tertiary care, so-called tertiary care, I don't call the Indian center as tertiary care center. We call this center as multi-level care. You know why? The reason is our Supreme Court says that I can't refuse any patient whether he is referred by somebody or he is not referred by somebody. Therefore, in my practice, I see a lot of patients who are referred, means tertiary care, but I also see primary care and secondary care. Whereas in the West, maybe things are quite different. Referral system is so strong and so much imposed that actually some center would see only tertiary care patient. So what are these biological factors which led us to believe that gut should be above brain? These biological factors in patients with IBS constipation include fecal evacuation disorder, slow colon transit, or a combination of two. Whereas in IBS diarrhea, it could be lactose or fructose malabsorption, bile acid malabsorption, non-celiac wheat intolerance. Let me tell you here, some people say non-celiac gluten sensitivity, but this term is not really correct. It should be called as non-celiac wheat sensitivity and FODMAP intolerance. Obviously, lactose and fructose, they are FODMAP. Small intestinal bacterial overgrowth and dysbiosis, immune activation, and post-infection IBS. Now, I will deal with small intestinal bacterial overgrowth primarily, but some aspect of the dysbiosis will also touch, which are qualitative change, which is qualitative change in the microbiome.
Thank you, Dr. Ghoshal. So today, in the interest of time, we are going to stick to only small intestinal bacterial overgrowth. But you brought up some very interesting things like, non-celiac wheat sensitivity, or is it non-celiac gluten sensitivity? So in my world of functional medicine, we look at food sensitivity in general, but I'm not going into that. One of the things, Dr. Kushal, you brought up about slow transit. Now, I know your research is lot of your research is focused on gut motility. So is there a difference in the gut transit time in, Indian people versus people in the West? Because definition of constipation in India would probably be different from what it is in a lot of the Western countries, right?
Yeah, that's right. So Indian gut transit time is quite fast.
Mm-hmm.
A whole gut transit time in Indian population is half of that in the West. So the reason could be multiple. So
Mm-hmm.
one is truly they have a fast gut transit time. Other is a lot of Indians are vegetarian, therefore they take a large amount of fiber. Also because India lactose malabsorption is to the tune of around 70% in adult. So therefore, when they take milk, which is very commonly taken by the vegetarian people as a source of protein, that also increases the bulk of the stool. So altogether, this contribute to the fast transit time. Now, yes, the definition of constipation is different because in the West, it is popularly said that more than 3 stool per week is normal. So that means if somebody is fasting 4 stool a week, this is normal. In India, we did a study and
Yes.
we found about 90 to 95% people pass 1 to 2 stool a day. That means their normal is 14 stool a day. So the moment they have even 5 stool, they will come with constipation.
Yes.
Also look at the stool form. In the Western situation, like Rome criteria says that if somebody is passing Bristol type 1 or type 2 stool predominantly means more than 25% of the bowel movement, then this is constipation. We found if you apply this criteria, a lot of our constipation patient, almost more than half of our constipation patient would not be diagnosed having constipation. So we extended the definition further, and we found if you apply stool form 3, Bristol stool form 3 as constipation, then you do better as far as definition is concerned. So therefore, the definition of constipation in India is different that in the West.
Thank you. So, what Dr. Ghoshal mentioned was the Bristol stool scale, and you can get an image on Wikipedia. It's free, and that is something we use in our intake questionnaire. So it has an image of what is the type of stool and the different types: type 1, type 2, type 3, up to type 7. So that is a very useful tool to incorporate, and I'll see if I can post a link to that in the video. So this one, Dr. Ghoshal, this meta-analysis, will you tell us about this?
You see, what happens is that we wanted to see that how common is bacterial overgrowth among patients with IBS based on the studies available in the world. And what you can see here is that there are at least 9 studies.
Hmm.
9 studies. Interestingly, of these 9 studies, 1/3 of the studies came from India.
Yes, I can see
Now,
that.
these 9 studies use glucose hydrogen breath test. In addition, some of these studies use jejunal aspirate culture and lactulose hydrogen breath test. So if you read our meta-analysis, we have done separate meta-analysis for bacterial overgrowth among IBS patient as compared to control using glucose hydrogen breath test, using lactulose hydrogen breath test, using jejunal aspirate culture. And what we found is whatever may be your diagnostic method, patients with IBS more often have bacterial overgrowth than the control population. Second is if you further see that which subtype of IBS more often have bacterial overgrowth, we compared patients with IBS diarrhea versus IBS constipation. And what we found is it is IBS diarrhea predominant subtype, which is more often associated with the bacterial overgrowth. So bottom line of this meta-analysis is bacterial overgrowth is common in IBS than healthy control, and diarrhea predominant IBS more often have bacterial overgrowth than constipation predominant. This meta-analysis is from our group, but this at the same time, almost simultaneously, this is in the beginning of 2000, 2 other meta-analysis came. One was in Journal of Neurogastroenterology and Motility, published from Italy, and other was in American Journal of Gastroenterology, published from Australia. And all 3 meta-analyses showed almost similar results. So now it is clear that SIBO is more common in IBS.
So again, this is what are the symptoms of small intestinal bacterial overgrowth? I think we briefly mentioned this. Now, Dr. Kushal, we won't have time to go into that, but you mentioned methanogens. Will you just explain just in a few sentences what is the relationship of methanogens with IBS and SIBO, and why is it so important?
Yeah, so this slide shows you that all the IBS symptoms actually are also there in SIBO patients.
Hmm.
So therefore, that's why there is a confusion. People of SIBO will be diagnosed as IBS, and IBS patient more often have SIBO. We go to the next. We go to the next.
Okay. So you will.
Please go to the next. Yes. So I will talk about methanogen then. Yes. Now we skip this and go to the next.
This is the.
Next. Oh, this is also next. I think this is how to diagnose SIBO, which already we elaborated. Next. Oh, we skipped some
No,
of this
I
because
think.
you quickly want to come to methanogen. Yeah, so then we'll take your question on methanogen later.
Okay.
But as I told you, jejunal aspirate culture is the method to diagnose SIBO. At least this is the gold standard, though breath test is an alternative. So go to the next. Next. Now, this study is very, very important. That means this study shows you that nowadays people are treating IBS patients with antibiotics such as rifaximin. But what happens is, if you look at the famous target study, which was published in NEJM, the
Yes.
response of rifaximin in a non-constipation IBS was 40%.
Mm-hmm.
Response with SIBO was 30%.
Mm-hmm.
That means if somebody got treatment with rifaximin, he had a chance of incremental chance of improvement only by 10%. Because this was statistically significant, FDA approved rifaximin for use in non-constipation IBS. But we had something in our mind. See, what we wanted to ask is, if somebody has SIBO with IBS, he is more likely to respond than any patient with IBS, because this study took any patient with IBS,
Mm-hmm.
obviously not constipation with IBS, but non-constipation IBS, but the target study did not diagnose SIBO among them. So this is a pilot study where we took 80 patients of IBS. We actually did jejunal aspirate culture. We found 15 of them had SIBO. Now we randomized them to norfloxacin and placebo. Why norfloxacin? That time rifaximin was not available in India. And those who were SIBO negative means colony count was less than 10 to the 5 colony forming unit per ml. We randomized to norfloxacin and placebo. Interestingly, 87% of IBS patients who had SIBO responded to norfloxacin compared to only 25% those who did not have SIBO. Now, if you pull this data, now what you do is all 80, 40 were treated with rifaximin, hey, norfloxacin. So of these 40, 15 responded to norfloxacin, which gives a figure which is similar to target study of about 40%. So it is actually 37.5%, which is close to 40%. That means if you do not select the patient for SIBO diagnosis, your response to antibiotic will be low. Now go to the next.
So before we go to the next slide, Dr. Ghoshal,
Next.
one quick question about rifaximin. I know you were
Yes.
instrumental in getting rifaximin to India, and maybe that is
Yes.
for another video. Now, why did you choose norfloxacin versus something else? Was it based on aspirate culture, or was it based on your experience?
Yeah, we did a study earlier. That study was published in 2003 or 2004. Now, actually, in that, we took patients, I think 50 patients, who underwent jejunal aspirate culture. In those 50 patients, in 30, there was growth of bacteria. And we looked at sensitivity of these bacteria to different antibiotics. And what we found is the highest sensitivity, or the sensitivity was most frequent, or bacteria were sensitive most frequently to ciprofloxacin and norfloxacin.
Okay.
Also, norfloxacin is not really absorbed very well from the GI tract, gastrointestinal tract. Therefore, we wanted local action
Mm-hmm.
than
Something like,
using ciprofloxacin, which is absorbed and there is a problem of resistance.
oh, this is interesting because rifaximin, one of the advantages with rifaximin is because it's a locally acting antibiotic. So interesting to know that Norflox also has similar action. So this was again another study
So
showing.
this is a study from China
Mhm.
showing the same, that if somebody has SIBO is more likely to respond than if somebody doesn't have SIBO
Mhm.
among IBS patients. And next, this is Mark Pimentel study, which is published just recently.
Yes.
Obviously, there is no jejunal aspirate culture in this. This study, they showed that if somebody is lactulose hydrogen breath test positive, is more likely to respond to rifaximin than if he is not lactulose hydrogen breath test positive for SIV. So the three studies available in the literature today
Mhm.
shows that actually, if you treat somebody with antibiotic, if he has a SIBO, he has a much higher chance of response than what is reported in target study. I think we can skip this. it is a complicated science, so we make it very simple. Next, you can skip this also. I think this is related to post-infection ideas. We come back to your question of, methane. Very, very important question.
Okay.
Let me tell you, serotonin or 5-hydroxytryptamine is a very important molecule for the gut. It is important for gut sensation. It is important for increasing gut motility, and it is important for gut secretion. So secretion, sensation, and motility, everything is increased by serotonin. Interestingly, serotonin, 95% is present in the gut. Only 5% is in the brain. But look at all the sort of this neurologists or psychiatrists, they deal a lot with serotonin, whereas gastroenterologists, unfortunately, did not bother much with serotonin. It is better not to discuss all those why. So we'll go to the next. But important thing is that if there is a serotonin deficiency, it will cause constipation. Whereas if there is a serotonin excess, it will cause diarrhea. Next.
So, Dr. Ghoshal, a little bit about the serotonin that you talked about. Now, the gut serotonin, can it cross the blood-brain barrier and go into the brain?
Not really, not really. Gut serotonin does not cross blood-brain barrier. What happens is that's why nature has given two enzymes, separate enzymes. So one is TPH1, tryptophan hydrolase 1, and other is TPH2. So one enzyme is in the gut and the other enzyme is in the brain because the 5-hydroxytryptamine cannot cross. So what happens is we take tryptophan in our diet, like cereals is a very rich source of tryptophan. That's why when you have a very good meal with a lot of cereal, you tend to be sleepy because you got a lot of tryptophan in your food. Now, what happens is that therefore, these two, the tryptophan goes to the brain, and there TPH, uh, brain TPH converted to serotonin, whereas gut TPH, actually what serotonin it produces doesn't go to the brain. But one important thing to understand here is it is not only the human TPH that is responsible for serotonin biosynthesis. In fact, there are gut bacteria which tend to have similar activity to convert dietary tryptophan to serotonin or related molecules, serotonin or related molecules. So that's why microbiota is very important for sensation, motility, and as well as secretion. Go to the next. On the other
And
hand, there are microbes in the gut. These microbes are called methanogen. These are methanobrevivectors, smithi predominantly, but there are other species also. So methanobrevivector smithi, what it does is, when the other bacteria produce hydrogen from the carbohydrate present in the gut lumen, these bacteria consume that hydrogen, convert this hydrogen, 4 atoms of hydrogen is combined with 1 carbon, and it produces methane. Now, methane tend to reduce serotonin activity in the gut. So therefore, methane excess means the reduction in the serotonin activity, and that leads to slowing in the gut transit. Now, you want proof for this. These are the 3 studies. 2 studies are from US, from Mark Pimentel group, and 1 study from our center. The first study was retrospective, and the 2 other studies are prospective, randomized controlled studies. And what it showed is that if you have patients in whom you actually have slow transit constipation with excess methane production, there if you give rifaximin, rifaximin reduces the concentration or amount of serotonin in breath, it improves gut motility, and it improves constipation. So therefore, bacteria are not only causing diarrhea, like I showed you, bacterial overgrowth is associated more often with diarrhea predominant IBS, but a proportion of subjects have methanogens in their gut, and that can cause constipation.
Thank you, Dr. Ghoshal. This is very interesting. So, when you say that methanogens, particularly in constipation IBS, now, other than doing a breath test, do you think that studying the gut microbiome, the type of bacteria in the gut microbiome, would tell us whether this person could be having methanogens, or is it the breath
Yeah,
test which is more accurate?
no, no, it is a very good question. I tell you, we did a study. This study was published in Gut and Liver. So what we did is we took patients who are methane producer and those who are not.
Hmm.
Now we looked at different bacterial species by real-time PCR. Okay,
Okay.
real-time PCR. And we found an amount of methanobacterus methi or presence of methanobacterus methi and other methanogen correlate with the amount of methane produced in the breath. So therefore, merely presence of methanogen in the
Yeah.
stool by real-time PCR or next generation sequencing can give you an idea. But I tell you in India, doing a real-time PCR on NGS, rather NGS particularly, would be more expensive than a breath test because in India, at least in our hospital, a breath test cost only $3.
Mhm.
$3.
Yes, but that is your institution, Dr. Ghoshal. It is not not the case all over India. But at the same time, it
Yeah,
is good to know that it is available. So that is very important because so basically, again, now we are at the conclusion. So, Dr. Ghoshal, what are the major takeaways for anyone who's listening to this or watching this video?
I want to tell IBS is multifactorial in pathogenesis. IBS is a syndrome and not a disease.
Mhm.
Now, it has multiple pathogenic factors, both at the gut level and the CNS level or nervous system level, even enteric nervous system also. Central factors important. We are not ignoring those. But peripheral factors, I believe, are of major importance. But you can say I have some bias because I'm a gastroenterologist. And what happens is we do a lot of work on the microorganic aspect of IBS. So I acknowledge that. Now, let me tell you, all these factors interact with each other. Like I told you, the microbiota, they
Mhm.
can deplete serotonin, they can also produce serotonin. Now, serotonin is associated with motility, sensation, so they are all interacting. And finally, I tell you that small intestinal bacterial overgrowth is an important factor in pathogenesis of IBS, particularly those with IBS diarrhea. Don't ignore it. And you ask me a question, can we treat this patient without doing a breath test or jejunal aspirate culture? Yes, you can.
Yes.
I tell you, what we tell in India, I can only tell the situation in India.
Yes.
I tell my physician colleague that if somebody has a lot of bloating, if it is a diarrhea predominant IBS, if IBS symptoms started while on PPI, proton pump inhibitor, if somebody's hemoglobin is on the lower side, it is normal, but still on the lower side, because if it is really low, then you will investigate is it an organic disease rather than IBS. But in the lower side of normal, if you find a hemoglobin value, if IBS patient is little elderly,
Mhm.
now, if he tells you that I responded to a course of antibiotic earlier or probiotic earlier, so you suspect this fellow may be having SIBO. And in those situations, you can give a trial of antibiotic.
Thank you. So that is actually usually when patients come to me, they have already been treated with rifaximin. And in a country like India, where people have to pay for everything, actually a course of rifaximin is way cheaper than getting a jejunal aspirate done in the private sector. I'm not talking about your institute,
Yeah,
or
right.
getting a
Right.
breath test done
I
as
agree.
well. So that is very important. And the other thing is, Dr. Kushal, now we know that SIBO recurs a lot. So, what would you recommend? Do you recommend that if someone is doing a jejunal aspirate, they should do a culture sensitivity, or I mean, a lot of gastroenterologists do a jejunal aspirate. So, do they routinely do a culture sensitivity, or that's not really the practice?
Uh, I don't think it is needed. If you look at the data from Mark Pimentel,
Yes.
both in vitro study and in vivo study,
Hmm.
he showed that rifaximin treatment is not associated with development of resistance so often among bacteria compared to other antibiotic treatment.
Mhm.
Second thing, I tell you that the response of rifaximin, or in other words, sensitivity of bacteria to rifaximin is very high. So you don't really depend on sensitivity testing to treat this patient. But I tell you, when it recurs, see, recurrence is rather rule rather than an exception. Like I remember there is a study which Dr. Sanjeev Sachdeva did in GB Pant Hospital, New Delhi. He followed a patient after successful treatment with rifaximin using breath test, and he found over 6 month time more than 50% patient
Mm.
recur.
Yes.
Now, how to treat recurrence? Look at the Target 3 study. In Target 3 study, which was published, I think, in Clinical Gastroenterology and Hepatology, that is the sister journal of gastroenterology, where they showed actually repeated rifaximin treatment led to response. So if symptom recur, you can repeat rifaximin again and again. Now, there is a study from Mark Pimentel group
Yes.
where what he did is he treated a patient, or rather, it is a retrospective analysis of data. He showed that those who received prokinetic, such as erythromycin or prucalopride, they tended to recur less often. Their SIBO tended to recur less often than those who did not receive these drugs. Therefore, I would say yes, recurrence is common. Treat with prokinetic, which will improve motility, therefore recurrence will be less. There are also data to show that antibiotic followed by probiotic reduces recurrence. And lastly, what I said is that if it recurs, you can retreat with rifaximin.
So, Dr. Kushal, what is the dosage that you recommend for rifaximin and how long should people take it?
You see, the standard dose which Target study used is 550 milligram thrice daily for 10 days.
Mhm. So, 550 is available in India, as I understand.
Yeah, yeah. In India, we have 200, we have 400, we have 550.
Okay, so 10 days is enough. It doesn't have to be for 2 weeks.
Yeah, that's right.
Okay, thank you. I think that was the last slide. So, Dr. Kushal, thank you so much for investing your time. There are so many questions that I have, but I think because we have already exceeded our time, I'm not going to go into that. Some of the major areas are you talked about, post-infection IBS, and thank you so much for differentiating it between. I don't know why they were calling it post-infectious IBS before, because it's not an infectious disease. So, given that India has such a
No, we
high,
changed. We
I
changed
know,
that.
yes,
Yeah, in Rome, we changed that. Yes,
yes, I noticed that. And I
yes.
used to wonder, why are they calling it post-infectious? So given that, Dr. Ghoshal, in India, there is a huge burden of waterborne diseases even today. Uh, and you talked about, now we didn't have time to get into that, the post-infection IBS and the post-infection malabsorption that you have covered in another paper of yours. So how does that differentiate between what people see as IBS in Western countries where they don't have such a high burden of waterborne diseases? How much of a difference does that make really?
I tell you, see, what happens is in a study, we found that IBS patients who come to us in outpatient clinic, only 10 to 14% developed it following an acute gastroenteritis.
Mhm.
What does it mean? That IBS, post-infection IBS, is not more frequent in India than reported elsewhere in the world,
Mhm.
because the frequency among sporadic IBS patients is around 10 to 14%, which is quite similar to the report from other countries. So
Mhm.
how could it happen? The reason could be that when a fellow get exposed to an infection from their childhood, they develop a good T regulatory response.
Yes.
So when you have a very good T regulatory response, in response to an infection, you mount an immune attack on the germ. But once the infection is cleared, actually your immune system knows how to switch it off.
Mhm.
And this is what we have learned also in the COVID pandemic. People were not believing us. But let me tell you, you just look at COVIDometer and you realize the death rate in India is much lower
Lord.
than any other countries, because this all these influenza things happen so frequently in India, and people don't even bother about it. So question is, the T regulatory response is good. So cytokine storm in response to an infection is not so much. Now we did a study in Bangladesh where we followed up these patient, acute gastroenteritis patient for 1 year using Rome 3 criteria. And we found 10 to 15% patient develop IBS following an acute gastroenteritis episode compared to control population who did not have gastroenteritis. Now, let me tell you, you'll say this is 10%, which is very similar to other studies in the world. No, there are studies in the world which showed the frequency was as high as 30%. So our frequency was rather lesser. But even then also, I will further give an argument that our patient had severe gastroenteritis. The Bangladesh study that we did, all the patient had severe gastroenteritis and all the patient were admitted to ICDDRB, Dhaka, Bangladesh. So these are really severe gastroenteritis patients. Still, our rate of IBS was not so high. Now, yes, in those patients, we did in a subset D-xylose test, fecal fat estimation, and duodenal biopsy to know how commonly those patients who have post-infection IBS by Rome criteria actually have post-infection malabsorption, which is called tropical sprue. And what we found, 10% of patients who have post-infection IBS by Rome criteria actually had tropical sprue. Now, people thought tropical sprue is a disease of India. People wanted to write the obituary of that disease. I think once you open your eyes with curiosity, you get things everywhere in the world. So what happens is now you need data on that. There had been study which is published in Digestive Disease Science from Washington, D.C. American soldier posted in Iraq war, they developed tropical sprue. And I remember, oh, that was a study, oh, that is the study, yes. So therefore, tropical sprue occurs even US today. The Iraq war soldiers, they went back and they developed tropical sprue.
Yes, actually, that is true because a lot of people, even from Canada, before the COVID, they used to travel to Mexico, and many of them would come back with, some GI disturbances. So, because of the extensive travel, I think a lot of diseases have, become more common in countries where they weren't common before. So that is very interesting finding. So, thank you so much, Dr. Ghoshal, for investing your time. Maybe, hopefully, I will, have the opportunity to, discuss more things because there are 20,000 questions actually roaming around in my head because of, so one of the interesting things is, Dr. Kushal, you had a paper on the serotonin transporter gene. This was a few years ago because you brought up serotonin. So that was also, that is probably
Yes.
another, one quick question about serotonin. So checking for serotonin in blood, so serum serotonin, what I understand is that will not reflect the serotonin levels in the gut. Is that correct?
Yeah, that's right. That's right. So it is better that you actually check for serotonin in the gut. And in fact, in that study, we took rectal biopsy and checked serotonin in the rectal biopsy, not in the blood.
Yes. So thank you very much. And maybe next time we're going to talk about something else that is interesting for you.